Welcome to AETCM, the Emergency Medicine channel.
Yeah.
76-year-old female patient came to our ER with acute onset of breathlessness, which was progressively worsening since 6 hours. Initial 10-second assessment, patient was conscious and oriented, tachypneic, was not able to complete the full sentence. Primary survey, airway was patent, no stridor, nor gargling, no hoarseness of voice. Breathing, respiratory rate is 36 per minute, SpO2 90% in room air, and the patient was using of aspirin muscles of respiration, and air entry was bilaterally equal with bilateral collapses present. At that time, we put the patient in proper position and connect to 5 liter oxygen facial mask.
Okay.
Circulation part, BP is 180/90, heart rate is 110 per minute, peripheral pulse are palpable, CRT less than 2 seconds. Disability part, GCS C4 V5M6, people is bilateral equally reactive, GRBS is 249.
Okay.
Exposure part, temperature was normal.
Okay. So we have an elderly female who has presented with acute onset of breathlessness within 6 hours of duration. So before 6 hours, whether she had any breathlessness or it's a sudden onset of breathlessness?
Before 6 hours, baseline is MMRC grade 2, while exertion she have
Okay. Now there is sudden worsening since last 6 hours. She has come to the emergency room, and what was the respiratory rate was?
36 per minute.
36 per minute. Saturation?
90 on room air.
90% on room air. Okay. On auscultation, bilateral? Air entry was there and bilateral crepitations were there. So what you are dealing with are probably bilateral crepitations with fluid overload, probably pulmonary edema. That is what we can grossly say. So we have to initiate her on oxygen. That's the first thing. Whether to start her on BiPAP, that all depends upon. There is no contraindication. Definitely BiPAP will be the additional first choice of your initiation for your airway management and breathing management as well. And what is the target oxygenation that you wanted in this lady? About 95%. So that is what our target is. So since there is crepitation, increased work of breathing, bilateral crepitations, we can take into pour into a favorable of a pulmonary edema. 6 hour duration. So what was the blood pressure for the patient?
180/90.
180/90. Okay. Now I wanted to know what are the comorbidities for her.
Patient is hypertensive,
Okay.
diabetic, diabetic retinopathy,
Okay.
and CAD patient.
Okay.
PTCA done in 2018.
Okay.
Patient was on metoprolol 25 mg
Okay.
and atorvastatin 80 mg,
Okay.
ticagrelor 90 mg, and on eccospirin.
Okay. So what do you think will be the trigger for her to come to the ED? What do you feel?
Acute exacerbation
Of this pulmonary edema? She's having pulmonary edema, there is no doubt. So it is not like a chronic heart failure patient that is coming to the ED. It is an acute onset. That is for sure, 6 hours. Usually this chronic heart failure patient, they will have progressive breathlessness, worsening, and one day they will come to the emergency room. Maybe you need to just give them diuretics, but this sort of an acute presentation. So acute presentation, what is the other terminology of pulmonary edema that we can call it?
flash pulmonary edema.
It can be called as flash pulmonary edema, or what is the SCAPE? So sympathetic crashing acute pulmonary edema. That is very classical of what you are saying. Is looks like a sympathetic crashing acute pulmonary edema. And what are the possible reasons of a trigger? And our patient management is similar to any other pulmonary edema management. Initially we need to put her on an NIV, airway management, breathing, and next important thing will be furosemide. You need to give diuretics and hypertension. So this is one area where we can use our NTG as boluses. Okay, so usually when we use NTG, we give it as an infusion. But when you have a BP of 180, 100 or 200/120, you want to bring down the blood pressure, and this is one area where you can give maybe a 200 microgram of NTG as a bolus. You can give it a try. So that is one area where we can use NTG boluses, is sympathetic crashing acute pulmonary edema, and definitely you can start on an infusion also. So our strategy will be first to secure the airway, as you said rightly. You have put on an NIV. Second thing, you have to control the blood pressure and oxygenation by giving adequate amount of oxygen NIV. And why we are starting NTG?
Due to decrease the venous return, the BP also decrease, and fluid can also decreases.
Okay, so the main reason it will be what reduction will happen?
preload decreases.
It will decrease the preload, and also that in terms, if there is an ACS also, it will also help. It is an acute coronary syndrome, can be one of the precipitating factors. So that part also it will help. So these are the main agents. That any other agents that you wanted to give in here? Furosemide, yes, you can give 80 mg or 100 mg, and maybe as an infusion also. Any other agent that you wanted to give?
Hydroglycerin.
Oh, maybe not. I prefer using nitroglycerin in this lady. So anything else that you wanted to keep her settled down or something? Morphine definitely not to relieve anxiety. It has also action on your pulmonary vasculature. So it will also help in venodilatation. So morphine can be tried. The problem is that you should not be using a very high dose of morphine. Maybe a 2 mg of morphine. Even subcutaneous morphine will work in this situation. If you are worried giving in an IV morphine, that you are worried, okay, because the respiratory depression happens or not, we can even give 1 to 2 mg of subcutaneous morphine. That will release the patient's anxiety. And already why it is there, why the patient is having this sort of a presentation, what will be the main important reason? She would have missed a antihypertensive dose. Or the most common will be a diastolic heart failure. See, in emergency room, what we commonly think that it is an LV failure. So LV failure, on top of that, we think that it is basically a systolic failure. It is more of a systolic failure, but this sort of crashing acute pulmonary edema definitely have a diastolic component also. So you know the Sterling's curve. So the Sterling curve, what will happen when there is a sudden increase in the diastolic volume? Contractility again come down. So that will take on, and the patient have minimum fluid overload. Imagine that the patient has got an usual intake of like 2000 liters of fluid. Last night might be she have taken an extra fluid. They can suddenly come back to the ED with a similar episode of an sympathetic crashing acute pulmonary edema. And the beauty of it is that if you give good diuretics, they will settle quickly also. So these patients will be settling if you are treating them with NIV, Lasix and NTG. Within maybe 1 or 2 hours, they will be completely normal and they will be off BiPAP also. That can also is a possibility. So this sympathetic crashing acute pulmonary edema is very, very common. What are the triggers? What are the reasons why we get such patient in the ED? Mostly diastolic dysfunction is what we need to keep in our mind. Diastolic dysfunction we don't think, because chronic hypertensive patients, they will have a diastolic dysfunction. A grade 2 or a grade 3 diastolic dysfunction will be there. On top of that, they are missing an antihypertensive. They are having an excess fluid overload, or they're having a new onset arrhythmia or a new onset of an myocardial infarction that will trigger. So the most common reasons is any of this. So whether she has got any of these things that has happened recently, or maybe an infection that might have triggered her to have an heart failure. The demand has increased suddenly. So that is the normal our pulmonary edema. But this is sympathetic crashing. What is the pathophysiology behind the sympathetic crashing pulmonary edema?
Sympathetic surge is the...
So basically there is a lot of sudden surge of this adrenaline. So all those things is causing and increasing the heart rate, increasing the blood pressure, and as a result the patient is going for an heart failure. So what we need to do, we need to stabilize the patient by providing these things. And nitroglycerin we usually start as an infusion. What is the dose of usual nitroglycerin infusion?
Normally ERV 5 microgram per minute.
Yeah, you can start with 2.5 microgram per minute and you can go up to 200 microgram per minute. So that is the dosing that you have to think of nitroglycerin. And as I said earlier, this is an area where we can try a small boluses of nitroglycerin where you wanted an acute BP reduction. So we have to be very careful, because if we give nitroglycerin, like, it can cause further hypotension also. That also we don't want. So very carefully, maybe 200 microgram bolus or something like that. If it all depends, maybe over 2 minutes or 3 minutes, you can give a small boluses if the BP is not getting controlled. So then what are the other considerations that you need to keep in your mind for this patient?
Any electrolyte imbalance?
You have to get an ECG. Obviously, we will take an ECG. You have to look for any new onset arrhythmia, new onset myocardial infarction. Already she is having an higher risk CAD is already there. So that will be the next investigation that we wanted. BNP I will never send, because we are already pretty sure that it is a cardiac failure. There is no point in sending BNP. But where will you send BNP? In ED. Actually, when you ask me, when you do a proper clinical examination, there is no role for any BNP in emergency room. And definitely another thing that you can diagnose this thing is by your B lines. So B lines, with all those things, you can definitely think of focus you can use in here, and you look for B lines. So all together, we can think that, okay, you are dealing with a sympathetic crashing acute pulmonary edema. What is the other type of pulmonary edema that you will see? Again, renal failure patient, they can also come with the similar episodes like sympathetic crashing acute pulmonary. They have missed a hemodialysis. They can come to the ED with the similar way. Where are the other situation where you can see the flash pulmonary edema? Which other condition?
Anemic conditions.
Okay, that is a trigger. Where else you can see? Like this, the patient was absolutely fine. I am telling you a history, giving a history. Patient is absolutely fine. She is having some history of tremors in between. Now she is suddenly coming with an episode of pulmonary edema to you. What do you have to think? She had frequent episodes like this. She has come to the ED very frequently. What you have to keep in your mind? There, your treatment management is little bit different. That is the other clue. And I can give you one more clue. Etomidate is one drug that you can use in that situation. You're using a lot of etomidate as an RSI agent in the ED. This is a drug that can be used for the treatment of that. What is the side effect of etomidate? Adrenal suppression. Where you wanted adrenal suppression?
Adrenal crisis.
No, I'm not adrenal suppression. I am asking. Adrenal crisis means deficiency of adrenal hormone. When it is excess, where will be the adrenal hormones will be excess? Pheochromocytoma. So that is one of the presentation of that will be like this. They can come with pulmonary edema. They can have this anxiety, tremor, sudden surge. Pheochromocytoma is one thing that we need to keep in our mind. So pheochromocytoma, how will you manage? Pheochromocytoma, suppose you know that this patient is having a pheochromocytoma. So how will you manage?
Initially we give alpha blocker, then we give beta blockers.
That is the ideal thing. So what alpha blocker that is available in our pharmacy? Phenoxybenzone, I don't have, and I never used. Phentolamine also I have not used. It is not available. What drug we have in our agency is labetalol. Labetalol is basically an alpha and beta blocker together. Or you can give prazosin. So that is one agent, prazosin. That is, prazosin is the agent that we can use. You have to have an alpha blocker initially followed by a beta blocker. Otherwise what will happen? This unopposed beta effect
increase the hypertension.
Increase the hypertension again. So beta blocker should not be used as a first line agent. So similarly, you can use labetalol, which is 1:7 is the alpha beta ratio. So that is another thing. So what we will call the normal pulmonary edema, that chronic heart failure patients, you can call it as fluid overload subacute pulmonary edema. So two terminologies that recently they have come up, maybe the last 3 or 4 years they have come up with. One is SCAPE, as you said, sympathetic crashing acute pulmonary edema, and other terminology is fluid overload subacute pulmonary edema, FOSPE. So these are the two presentations by which the patient can come into the ED. The other one is a chronic heart failure patient. He has got a chronic heart failure. So he has come to the ED because last few days he have been worsening. Now he felt he is worsening with breathlessness. So he came into the ED. So the treatment may be just diuretics. They might not require this NIV management and all those things. When they are coming with acute onset of breathlessness, sudden onset dyspnea, sudden onset, that is very important. Sudden onset dyspnea, accelerated hypertension, the blood pressure is very much high. You are like seeing a blood pressure above 180, MAP above 140, 120. You are seeing, then you have to think in terms of an sympathetic crashing acute pulmonary edema. The most common differential diagnosis triggers that you need to remember will be your missed antihypertensive, maybe missed hemodialysis. All those things will be the most common reason. And diastolic dysfunction. We have a patient who, if she drinks excess 500 ml or 600 ml of fluid, she's taking, she will come to us with an acute fluid overload. So that much common is diastolic dysfunction, but we don't usually think of diastolic dysfunction in ED. But majority of the patient, diastolic dysfunction is the main reason why they are having a sudden failure and coming to the ED. So diastolic dysfunction, only thing that you need to restrict them on fluid for this group of patients who have the trigger, and adequate hypertension management also needed to be done. Okay, so again, X-ray you can take, you can confirm with the bilateral infiltrate, the curly B lines, and your bat wing appearance. You can use your focus to seeing for your B lines. The same curly B lines can be seen in your focus, that is the B line. Then as you told, the investigation, ECG, electrolytes. Which electrolyte is more important here? Potassium. Again, potassium is very, very important. And a blood gas, which will all give you an idea what is the underlying acid-base disorder that this patient is having. Anything else that you want to add on?
So the patient is CKD patient with totally follow patient.
Okay.
So when we take the ABG, the pH is 7.262, PCO2 is 25.4, and bicarbonate is 11.1.
Okay.
And creatinine is 8.06. Patient was not on dialysis.
Okay.
So metabolic acidosis with respiratory compensation.
So maybe the hypertension would have been the trigger here, and sudden surge of blood pressure because of the renal failure altogether would have triggered her to come to the ED, and she definitely required dialysis because whatever you give furosemide also the output and acid base disorder you cannot correct. She definitely need an hemodialysis. What she initiated on hemodialysis?
Because at that time on the ambulatory history, patient have decreased urine output since today onwards. Then patient developed the breathing difficulty and facial swelling is also.
Okay.
So nephroconsultation they do.
But again, and the patient was started on hemodialysis. As an emergency patient, our aim is pretty simple: ABCD management for any patient. But you need to know what ABCD management needed to be done for this patient. Any role for your bronchodilators here? Steroids? No, there is no role of steroids. But we can give these drugs when you have a component of an COPD copulmonary. So they can come with right heart failure. They can have acute exacerbation also sometime looks like an acute crashing pulmonary edema. They can mimic because underlying some copulmonary will be there. When you oscillate, some crepitations will be there. They will have hypoxia, but definitely their air entry will be reduced. There will be PCO2 build-up. So it can be a combination of both these things. Some fluid overload might be there for them also. For them, you can treat with, for bronchospasm, you can treat with steroids, and maybe furosemide also will help in those group of patients. But usually hypertension won't be seen. Once you settle their hypoxia and everything, that blood pressure will be normal. So that is one area where you can use your nitroglycerin. That is what I wanted to tell you. Okay, fine. Anything else? Okay. Thank you.